pinna are quite rare, especially in India, but you do see it in areas like Australia or areas where uh, you have exposure to a lot of UV radiation. So they usually happen in areas that is exposed to excessive sunlight and maybe an occupation in which the person spends a lot of time inside the sunlight. Maybe a farmer in Australia. These are the common carcinomas that are found here. This is squamous cell carcinoma, basal cell carcinoma, adenocarcinoma, malignant ceramoma, and melanoma. Right. The squamous cell carcinomas, they, as with all ulcers, they have a raised everted edge with an indurated base, and they have a tendency to metastasize to the regional lymph nodes. This is quite a rare presentation due to the poor lymphatic drainage of the pinna. So they can drain to the preauricular, postauricular, or even the parotid nodes. And they're commonly seen in males after the age of 50. And as I mentioned before, due to prolonged exposure to direct sunlight, these patients are more, these individuals are more prone to developing squamous cell carcinoma, especially of the pinna. There's two ways of treating this. One is through excision with a clear margin. And usually these lesions are presented at the early stage because it's a cosmetic deformity and people do tend to show the doctor quite early in the stage. But in case, this is just treated with local excision. And like I mentioned earlier, you have multiple flaps to close a defect in the pinna. If you come at an early stage before cartilageous invasion, you have a very, very good prognosis. The only concern for both the patient and doctor will only be the cosmetic outcome. With a larger tumor, which can extend into the external artery canal as well, this changes the prognosis drastically because we have to plan for extensive surgery, and these surgeries have a high level of morbidity and poor cosmetic outcomes as well. As you can imagine, if the lesion extends into the external artery canal, we'll have to remove part of the temporal bone as well. And there are multiple surgeries in which it's radical surgeries because we have to give a good margin if you want complete treatment. And this results in obliteration of a lot of the components of the ear. Maybe it will result in loss of hearing, maybe loss in the facial nerve as well because of extensive dissection. So if you have a lymphatic spread as well, which is quite rare, you have to plan for neck dissection as well. And MRND stands for modified radical neck dissection. And as I mentioned before, from the preauricular lymph nodes, it can spread into the parotid lymph nodes as well. And so a parotidectomy also sometimes has to be performed along with chemoradiation because of the microscopic extension of the tumor. Again, this scenario is really, really rare because most of these tumors are identified quite early because of the cosmetic outcome. But in case they are not identified, you have to go in for a more radical surgery. And this I have forgotten to add as well with reconstruction as well. There are many facial flaps as well. For example, a temporalis flap, which might have to be rotated to cover the defect that's caused by the end block dissection. You have basal cell carcinoma as well, which is basically present in the helix and the tragus. Or as you can see in the pictures below, they can be present in any areas which are exposed to direct sunlight. Again, this is mostly commonly seen in individuals over the age of 50, and they have a nodule with central crust. As you can see here, this is a central crust here. And lymph node metastasis doesn't usually occur. The treatment again is the same. It's wide local excision with a good margin around the lesion. And you have to address the reconstruction as well as the lymph node spread as well. So usually an MRI can be done in soft tissue lesions to see the exact extent of the tumor as well. So you get a rough idea of how much excision and what type of flap you need to reconstruct these defects. Coming to the external ear canal, there'll be two benign lesions we'll be talking about. There are osteomas and exostosis. And the malignant lesions are the same as I mentioned right now, and the management also will be the same. So if you have a malignancy of the external canal, you're quite unlucky, as they're only 5% of all the malignancies reported in the pinna or the external ear, and they're quite hard to deal with because they're identified quite rarely. I'll just talk about the symptoms for this. The management stays the same as I mentioned earlier, and I'll talk about osteomas and exostosis. So osteomas arise from the cancellous bone. They're a single, smooth, bony, hard, pedunculated tumor. You can see this here. And you need to make sure that you remember that these are pedunculated. So you can see here it has a small stem here. They often arise from the posterior wall of the osseous meatus. And the treatment is quite simple. It's just surgical excision. So usually what you do is you make a small incision of the skin here. You elevate the tympanomeatal flap here. You can just drill this off and reflap it, close the defect, and that should be all. So if you have a large osteoma like such right next to the tympanic membrane, you're going to have reduced hearing ability, and there's going to be conductive hearing loss in these patients as well. You can see here as well, this is quite an extensive one. And if it's really large, you might have to do a posterior auricular approach to get a good view of the bony external auditory canal. So this happens only in the cancellous bone, which is the medial part of the external auditory canal, as the lateral part is formed with or formed by the cartilaginous part. Exostosis on the other side, you can see it's not pedunculated. It's a smooth, sessile, bony swelling, the deeper part of the meatus. They can be multiple, and they arise from compact bone. So you can see here as well, they have no peduncle, and they project a bit like a mountain inside. And they're very commonly seen in divers or swimmers, and it's due to excessive exposure to cold water. This is also known as surfer's ear as well, because of continuous exposure to cold water. The treatment again stays the same. So you have to make an incision just lateral to the exostosis formation, elevate the flap, and you can drill off the excessive bone. And after this, you can lay in the flap. The most important thing about this is to prevent the causative factor. So these people have to use earplugs as well, or not go for swimming in cold water. So like I mentioned earlier, this is a small asymptomatic one, not causing conductive hearing loss. You can pretty much keep it under observation. The large ones impairing hearing or retention of debris as well, which is what I forgot to mention. So if you have the formation of wax, or if you have someone who is going to use earbuds, who's going to push wax into this aspect of the inner ear, middle ear, the external auditory canal, you're going to have accumulation there. And the debris that come from the tympanic membrane as well, they tend to accumulate here, in case it's a large one right next to the tympanic membrane. In those cases, you need to basically drill it off. A gouge and hammer were used back in the day, but it's not advised. A slip can result in a lot of trouble. Finally, again, malignant tumors of the external auditory canal. They have a history of long-standing ear discharge, and they may be extensions from a middle ear carcinoma as well. I think Rajesh will be talking about middle ear malignancies or carcinomas in the next class. And the symptoms are quite similar to something you might see in cholesteatoma. So it's blood-stained, mucopurulent discharge. It could be foul smelling due to erosion of bone or superadded bacterial infections. And they're going to have severe earache as well, if there's nerve infiltration. If there's no nerve infiltration, you're not going to see much of ear pain either. So the examination is it's quite normal in how you do an external examination as well. You might see an ulceration near the external meatus. You might see a bleeding polypoidal mass, a lot of granulation tissue, facial nerve paralysis. You might see that the tympanic membrane has been completely obliterated and there's a fungating mass arising from the middle ear. And you might, most importantly, see regional lymph node enlargement as well. So in these cases, it's very important not to go in for a biopsy right away, especially if you see a bleeding nasal polypoidal mass, because you're not really sure where they arise from. Even if they arise from a component of the horizontal part of the facial nerve, you can cause tugging and you can cause damage to the facial nerve, which can result in paralysis of the facial nerve as well. So in these cases, most often we plan to go for MRI or CT, or both are commonly done these days. So you go for HRCT of the temporal bone, which is a high resolution computer tomography of the temporal bone, as well as an MRI. So MRI gives you a good idea of the soft tissue involvement, and the HRCT gives you a good idea of the bony involvement. And you can plan and decide what type of management you have to do for these cases. So if you have an extensive lesion, as you can imagine in the temporal bone, there are multiple foramens from the skull base as well. If it's extensive lesions, you can plan for chemoradiotherapy, or if you are brave enough to operate these surgeries, you can go for a wide local excision. Again, this will be a drastic surgery, and the patient has to be ready to live with all the comorbidities of this surgery. As I mentioned earlier, there will be multiple skull-base foramens which open, and you might have to ligate multiple nerves, and the quality of life of these patients will be quite poor. And even after the surgical excision, they have to go for a post-operative radiation. The basic funda for surgery in any malignancy in any part of the body is, unless you can completely remove the mass, surgery is not advised. You can go for downstaging with radiation and then go in for surgery if you think it's feasible. But if you can't completely excise the mass surgically, it's not advised. All right, thank you. Just don't leave the class just yet. I'm just going to stop sharing this. I just need to take your attendance as well. Right, I think I've muted the conversations, so I can't really hear what you guys are saying. I hope you guys could hear what I said, and that's all. Thank you.